Hi everybody, my name is Mitchell Farmer and this is Laboratory 4, Part 1 of GI block. The first thing that I want to look at today is the duodenum. So the duodenum is split into, as you may know, 4 parts. The superior, descending, horizontal, and ascending part, also known as the first, second, third, and fourth part, respectively. So as you may recall, the first part is the only section of the duodenum that is intraperitoneal, or at least the proximal half of the first part is intraperitoneal, and the remainder of the duodenum is retroperitoneal, and it also wraps its head. The duodenum wraps its way around the head of the pancreas, which I have removed here. And also recall, in regards to the first segment of the duodenum, right here, the superior part, is a common site of ulceration from peptic ulcer disease, and that this ulceration typically occurs on the posterior wall of the first segment, and thus the gastroduodenal artery is at risk of also eroding, and then you having a internal hemorrhage. So the first part follows the pyloric sphincter, and then after the first part is the descending part, or the second part. I've removed the head of the pancreas here so we can look at the second part in a bit more detail, but as you can see, the second part receives the contents of the Ampulla of Vater, which is the location where the main pancreatic duct, seen here, and the common bile duct join and empty. So if I zoom in just a bit more, you can see here is the Ampulla of Vater, which is a combination of the common bile duct and the pancreatic duct. Now the Ampulla of Vater drains into the major duodenum papilla, seen here on the inside of the descending portion of the duodenum. Now the major duodenum papilla is important for a whole host of reasons. Not only does it allow for the emptying of pancreatic exocrine juices that allow you to digest your food, or exocrine enzymes, it also allows for bile to enter the duodenum, which allows for the emulsification of fats, but it's also important for several anatomic considerations. First is that it's an anatomical transition, or it marks the point of anatomical transition between the foregut and the midgut. Thus, it also marks the point of transition between the blood supply of the celiac trunk, which supplies the foregut, and the superior mesenteric artery, which supplies the midgut. Furthermore, it demarcates innervation as well, where you'd have T7 to T9 for the lower portion of the foregut existing above the level of the ampulla, whereas T9 to T10 to kind of L1-ish for the midgut existing below that level. Finally, the transverse mesocolon, which, as I stated before, unfortunately I can't put onto this model, but the transverse mesocolon also passes through the level of the minor duodenal papilla, the level of the major duodenal papilla. And this divides the abdomen into the supracolic and infracolic compartments, if you recall from your lecture with Dr. Walji. So this is an important anatomical landmark, and you should be able to find it once you cut open the second portion of the duodenum, or the descending portion of the duodenum. One thing that you probably will have trouble finding is the minor duodenal papilla, which is an opening for the accessory duct of the pancreas. We weren't able to find it. I'd be pretty surprised if you can. I'm just going to throw in the full pancreas here just so we can get an idea of how this all fits together now that we've gone over the Ampulla of Vater. So following the second part of the duodenum, we have the third horizontal part of the duodenum, or transverse section of the duodenum, passing horizontally at about L2, L3 vertebral level, and passes between the abdominal aorta and the superior mesenteric artery. I'm just going to pull up another view here so that we can look over that. 1 second. There we go. So, as you can see here, I've added in the diaphragm as well as the jejunum, and zooming in here, we can see the superior mesenteric artery, which, as I rotate, we're looking at anterior, and as I rotate lateral, we can see it travel anterior to the duodenum here, and then zoom in for you, anterior to the duodenum here, and then travel posterior to the body of the pancreas before entering the abdominal aorta. And so you can see that the third section of the duodenum is wedged between the superior mesenteric artery here and the abdominal aorta here, this transverse section right here. And that can be a potential point of constriction, say if you had an aneurysm of the abdominal aorta pushing the third section of the duodenum against the superior mesenteric artery. Now finally, the fourth part of the duodenum is where you have the transition to jejunum in what's known as the duodenojejunal flexure, which is a 90-degree turn seen right here. Also at this location is the attachment point of the ligament of Treitz, or the suspensory ligament of the duodenum. If I rotate from an anterior view, which we currently have, to a posterior view, I can show you that. Here is the ligament of Treitz. So this is a slip of muscle or fascia from the right crust of the diaphragm as it creates the esophageal hiatus. So if I kind of show you from an inferior to a superior view, you can see how this comes up in here, and from the right crust of the diaphragm, it would come up and aid in the creation of the esophageal hiatus right here. It's not perfectly shown in this diagram, but you'll hopefully be able to see that on your cadaveric dissection. And also importantly, you can see how it attaches to the duodenojejunal flexure right here. Now the reason this is such an important anatomic landmark is because, as you may know, it distinguishes upper GI bleeds and lower GI bleeds. And recall, an upper GI bleed is a GI bleed that's proximal and presents with symptoms such as melena or dark tarry stool, whereas a lower GI bleed is distal to the ligament and results in symptoms such as bright red blood in the stool, or signs, I suppose. So that's kind of everything I wanted to discuss in the duodenum. Basically, you have the superior, descending, horizontal, and ascending portions, and then the relative anatomic, I guess you could say, context. The next thing I want to discuss is the superior mesenteric artery, which I am just going to pull up right now. Here. So this is an anterior view of where the superior mesenteric artery would come from. Basically, you have the abdominal aorta, and then if we kind of look just over the body of the pancreas, we can see the superior mesenteric artery about 1 centimeter below the celiac trunk, passing posterior to the pancreatic body, and then anterior, as previously stated, to the third portion of the duodenum. Now, I'm going to go ahead and remove these guys, and then, not the superior mesenteric artery, as that's everything that we're looking at, but I'm just going to remove the duodenum and the celiac trunk, and the abdominal aorta as well. Hide those. Hide this as well. And then I'm going to show you the posterior view of the large and small intestine and how the superior mesenteric artery is organized. I'm going to go from superior to inferior, going over the unilateral branches of the superior mesenteric artery, okay? So the first branch that you'll see is the inferior pancreaticoduodenal artery, which supplies the pancreas head and uncinate process and the adjoining duodenum, along with the anterior and posterior superior pancreaticoduodenal arteries, which are both branches of the gastroduodenal artery. If you recall, I said there was an inferior pancreaticoduodenal artery that anastomoses with a superior and anterior one. This is where it comes from, the first branch of the superior mesenteric artery. If we continue to move inferiorly, superior to inferior, we'll then come across the middle colic artery, which splits into right and left branches. So you can see this little branch here, which then quickly splits into right and left branches. It supplies the proximal 2/3 of the transverse colon, excuse me, and anastomoses with the right branch of the right colic artery, as seen here, and the left branch with the left colic branch of the inferior mesenteric, which I'll show you shortly. But if we continue moving inferiorly, we will come across, as I had previously selected, the right colic branch, which anastomoses with the ileocolic inferiorly and the middle colic superiorly. And this is the ileocolic's colic branch to be specific. Now the right colic supplies the ascending colon, which I've highlighted here. Now continuing inferior more, the next thing we come across is the ileocolic artery. The ileocolic artery has two major branches. It has a superior colic branch, which supplies the ascending colon and anastomoses with the descending branch of the right colic artery, and it has an inferior ileal branch, ileocolic, pretty simple. And this branches with the terminal portion of the superior mesenteric artery to supply the terminal ileum and cecum. It also gives off, importantly, especially in the cadaver, it also gives off the appendicular artery, which supplies the vermiform appendix, which is important for when you're doing an appendectomy. Unfortunately, this is the vermiform appendix, and this is the cecum. Unfortunately, the artery doesn't lead to the vermiform appendix in this model, but it will in the cadaver, or it will have a branch leading to that, a branch off the ileo branch of the ileocolic artery, that is. And then finally, the last thing that I want to talk about are the the jejunal and ileal branches, also known as the intestinal arteries. These branch off the left side of the superior mesenteric artery, left and right, and anastomose with each other to form arcades. As you can see, these loops here. These arcades give off vasa recta, which are not present, but they're basically really tiny arteries. And they supply the jejunal and ileal loops of the small bowel. Now, to kind of bring all this picture together, I'm going to throw in the inferior mesenteric artery now. So now I have the abdominal aorta here, which I'm going to remove. But coming off of it is the superior mesenteric artery with the branches we discussed, the middle colic, the right colic, the ileocolic, and then its terminal branch. And now I've added the inferior mesenteric artery. Similar to last time, I'm going to go superior to inferior, covering the arteries, what the arteries are, and what they supply, starting first with the left colic. So the left colic supplies the distal 1/3 of the transverse colon and the descending colon. So recall, this is the descending colon, this is the transverse colon, this is the left colic. So it anastomoses with the left branch of the middle colic artery. This is the middle colic artery. And this is its anastomoses with the left colic artery. And the left colic artery also anastomoses with the highest branch of the sigmoid artery. So as you can see, it gives a branch down to the sigmoid artery here, and it gives a branch up or superior to the middle colic artery, seen here. So that's the left colic artery. And just to reiterate, it supplies the distal 1/3 of the transverse colon and the descending colon. The inferior mesenteric also gives off the sigmoid artery. The sigmoid artery, numbering anywhere from 3, or sigmoid arteries, sorry, numbering anywhere from 3 to 4, somewhere around there, supplies, no surprise, the sigmoid colon, and anastomoses with the descending branch of the left colic, as we've seen already here, as well as the anastomoses with the superior rectal artery, which I now have highlighted here through this anastomoses. Finally, the superior rectal artery supplies the terminal, is kind of like the terminal branch. It's kind of more so like a continuation almost of the inferior mesenteric artery, and it supplies the proximal or upper rectum. So I've selected the rectum here, and as you can see, it descends down from the inferior mesenteric to here and supplies the rectum. And I haven't really covered the veins, but the veins are very, very similar. They look almost identical, actually. And the inferior mesenteric vein drains the hindgut structures that the inferior mesenteric artery supplies. So that's basically part 1 of laboratory 4. Part 2, you can now check